I'm Dr. Fakir Abadi, and this is central nervous system infections in adults. CNS infections occur in the cranial or spinal column, and they are important because there is significant morbidity and mortality associated with these infections. Emergent administration of antimicrobials are necessary, and oftentimes neurosurgical interventions may be needed to improve outcome. CNS infections may be caused by viruses, bacteria, fungi, protozoa, and helminths. And there are also non-infectious etiologies that may mimic CNS infections, such as neoplastic diseases, intracranial tumor and cysts, medications, collagen, vascular disorders, autoimmune disease. And lastly, CNS infections may be acute, subacute, or chronic. In this topic, we will focus on acute infections. Central nervous system infections are associated with significant mortality, up to 10% mortality in high-income countries despite adequate treatment, and it can be as high as 58% in low-income countries. And in those who survive central nervous system infections, there is significant morbidity, such as focal neurologic deficits, such as hemiparesis, cranial neuropathies. There could be hearing loss or memory impairment because of significant damage to the brain as a result of the infection. Here are some reliable resources from IDSA. So the guideline that was published in 2004 for management of bacterial meningitis is still the latest guideline that is used for community-acquired meningitis. There is also a 2008 IDSA guideline for encephalitis. And in 2010, there was a guideline for cryptococcal disease, which can manifest as meningitis. So for cryptococcal meningitis, this is the guideline for it. And 2017 saw the release of healthcare-associated ventriculitis and meningitis, which we will not cover in this topic. And there are other guidelines, including COXI guidelines for coccidioides meningitis, and also guidelines for neurocysticercosis. Here's the first learning objective. Explain the pathophysiology and clinical presentation of central nervous system infections. Here's some terminology. Encephalopathy in general refers to an alteration in mental status affecting the patient's cognition or level of arousal that may be due to infection, or it could be due to non-infectious causes. Encephalitis is inflammation of brain parenchyma associated with neurologic dysfunction. Meningitis specifically is an inflammation of the meninges and subarachnoid space, which we will explain further shortly. Meningoencephalitis is a hybrid presentation of encephalitis and meningitis. There is also aseptic meningitis, which is inflammation of the meninges with CSF pleocytosis, which means increased white blood cells in the cerebrospinal fluid, but no growth of typical pyogenic bacteria on routine culture. There's also other things that we will not cover in this topic, such as ventriculitis. And these infections in general can be considered community acquired or healthcare associated. And again, in this topic, we will focus on community acquired CNS infections. Let's take a look at the anatomy of the brain. So inside the skull, you can see that essentially the brain is surrounded by several layers. Meninges refer to the 3 layers of tissue membranes that serve to protect the brain and spinal cord. So this structure is similar for the spinal cord too. So when you essentially look, so there is the skull, and then you will essentially have a dura mater or dura mater, and then there is some blood vasculature, and then there is also arachnoid mater, and then there is subarachnoid space, and that is exactly where the CSF fluid is, and then between the brain tissue and the CSF is the pia mater. So you can see that when in fact, when people talk about blood-brain barrier, they're usually talking about blood CSF barrier, because in the picture in the right-hand side, you can see that for bacteria that travel to the brain through the blood, essentially they have to cross this layer between the blood vessel and enter CSF fluids. And then from there, that is where you have meningitis. So that is meningeal space. And then from there, they can penetrate the brain parenchyma. As I mentioned, encephalopathy is a general term that can be caused by many things, including infectious causes such as bacterial or viral meningitis or encephalitis, but also many non-infectious causes. Now, certain populations are at higher risk of developing CNS infections. That includes extremes of age, so older age, including people over the age of 50, but also infants. So in the first year or two of life, infants are at increased risk of CNS infection. Patients who are immunosuppressed, people with asplenia, either functional or anatomical asplenia, people with head trauma, and those with chronic medical and lifestyle conditions. There are two routes for CNS infections to develop. Most commonly is through the bloodstream infection. So an infection could be at another site in the body, and once it makes it to the blood, bacteremia will essentially take the organisms through the brain, because the brain is highly perfused, and then they can penetrate and enter the CSF, and then consequently enter the brain parenchyma. And occasionally there could be contiguous site infection, such as paranasal sinuses or mastoid of the inner ear. So people who have extremes of these infections, the damage can actually lead to entry into the brain space. And of course, another example of contiguous site infection would be head trauma. So, people who get into car accident, or, people who have had some sort of surgery, post-surgical, if there is an opening to the skull, that essentially leaves an opening for the bacteria to enter. Now, once CNS infections occur, there are a couple of things that happen. One is that, so in this picture, we're looking at this is the blood, and on top there is CSF. So once pathogens have made it to the CFS and infection has occurred, there will be significant release of cytokines, and there will be inflammatory processes that will take place. Part of that will make the blood CSF barrier leaky, so fluids will enter and lead to brain edema, and you will see that there will be increased pressure with the CSF fluids. The second thing is that essentially either thrombosis will happen in the vasculature, or there is vasospasm that essentially reduces perfusion, and that can lead to ischemia and damage to the brain. Let's take a look at clinical manifestations of CNS infection. Most commonly, and about 70 to 80% of patients will present with either headache, and these headaches are severe headaches, neck stiffness, fever, or altered mental status. Now, there are challenges with these because the classic triad, which was a combination of neck stiffness, fever, and altered mental status, is only visible in about half of the patients. So the other half may not have the classic triad. And the classic signs of meningitis, such as Kernig sign or Brudzinski sign, have poor sensitivity, so they're not really used anymore. Whereas in older textbooks, you will see that these signs are emphasized, but they have poor sensitivity, so they cannot really rule out CNS infection. In other words, if people do not have these signs, you cannot reliably say that they do not have a CNS infection or meningitis. And symptoms alone are insufficient to differentiate meningitis, encephalitis, or brain abscesses, because there is a large overlap between different types of CNS infection, because they often present as headache, neck stiffness, fever, and altered mental status. Some patients may present with nausea and vomiting. Let's take a look at some of the diagnostic tools that are available. So blood cultures should be taken in all patients suspected of having CNS infections, ideally prior to the administration of antibiotics, but this should not delay administration of antimicrobial agents. In fact, antimicrobial agents should be administered within an hour of presentation to the hospital in patients who are suspected of having CNS infections. And then in these patients, once contraindications are ruled out, there can be a lumbar puncture performed to collect CSF, cerebrospinal fluids. And there are two things done to CSF. One is kind of like a urinalysis. So you essentially analyze characteristics of the fluid. The second thing is the culture for identification of organisms, and if there is something found for susceptibility result. In recent time, there is also a CSF lactate that can be tested in CSF, and CSF lactate can accurately discriminate bacterial meningitis from aseptic meningitis unless the patient received antibiotics prior to lumbar puncture. So again, lumbar puncture is best done prior to the administration of antimicrobials, but again, lumbar puncture should not delay administration of antimicrobial agents beyond 1 hour. So on the CSF, of course, prior to culture, there is gram staining done that can be used for rapid identification of organism. And in fact, there are also molecular diagnostics that can be done on CSF. These are typically PCR, and the results should be available in a matter of a couple of hours, so that those are rapid diagnostics. And lastly, there is serum procalcitonin that can also be used to distinguish CNS infections from non-infectious causes of encephalopathy. Let's take a look at CSF characteristics. So when lumbar puncture is performed at the beginning, they can measure the opening pressure. So normally the opening pressure is somewhere between 12 to 20 centimeter of CSF. And by the way, the numbers in this table, depending on what reference you look at, you may come up with slightly different ranges of numbers. But the overall takeaway is pretty much the same. So kind of think of when things should be normal and when they are elevated or decreased. So when we say normal, we're referring to someone who does not have CNS infection or any CNS abnormality. So there is an opening pressure that's normal. The appearance should be clear. White blood cells should pretty much be absent, but no more than, it should be less than 5 cells per milliliter or cubic millimeter. And the dominance of these white blood cells should be monocytes. Protein should be less than 50 milligram per deciliter. Glucose should be somewhere between 45 to 80 milligram per deciliter, and glucose CSF to serum ratio should be 0.5 to 0.6. And the reason sometimes it's useful to look at the ratio is when someone has diabetes, for example, specifically uncontrolled diabetes, their glucose may be higher, and that may affect the way we interpret. So in those patients, it may be more accurate to compare the ratio of CSF to serum glucose, and that should be normally about 50%. With bacterial infections in the CNS, opening pressure will be increased. So as we saw through the inflammatory processes, there will be increased CSF, so pressure will be high. The appearance will be turbid. White blood cells will be significantly increased as these white blood cells are trying to attack the bacterial. And the dominance of those white blood cells will be neutrophils. And by the way, the terminology we use for increased white blood cell count in CSF is pleocytosis. So as a reminder, when white blood cells are increased in the serum, we call that leukocytosis. If white blood cells increased in the urine, we call it pyuria. And in the CSF, we call it pleocytosis. So we have specific terminology for these sites, whereas in other body fluids such as peritoneal fluid, synovial fluid, there's not a specific term for increased white blood cell. Okay, so the dominance is neutrophils. Protein will be increased. Now glucose will be decreased. And this makes sense because bacteria need to use that glucose to grow. So as they're consuming the glucose in the CSF, that number will go down. The same with if you look at the ratio. So normally the ratio should be 50%. So now that will drop to 40% because bacteria are using it. Now when it comes to viral infections, usually the opening pressure is normal. Appearance is clear, but they do increase white blood cell count. And here's what's different. For viral infections, the dominant will not be neutrophils, it will be lymphocytes. So lymphocytes have the primary role of clearing viruses. Protein will be increased. Glucose is usually normal, but it may decrease occasionally. So viruses, they're not self-replicating organisms, so they're not necessarily using glucose. And then for fungal infections such as cryptococcal meningitis, also opening pressure will be increased. The appearance may be clear or turbid. White blood cell will be increased with the dominance of lymphocyte. Proteins will be increased. Fungal species also need to use glucose to grow, so glucose will be low, and so will the CSF to serum ratio will also be low. Now let's take a look at causative pathogens in CNS infections in adults. For acute encephalitis, the large majority are unknown etiology, so typically nothing will grow on cultures, and encephalitis is mostly caused by viruses. So although most of them, we just don't know which virus because it's not easy to culture viruses. So essentially to identify viruses, you rely on, instead of a culture, we rely on, rapid diagnostics, and we may not necessarily have rapid diagnostic to identify every single possibility. So it's usually a select number of organisms that can be detected. So for the most cases, we don't know what's causing it. Number 2 is herpes simplex virus 1, about a third of cases. And then varicella zoster virus and West Nile virus. And number 1 is enteroviruses. Now let's take a look at community-acquired bacterial meningitis. And for bacterial meningitis, it's based on predisposing conditions. So one condition is age. So for adults up to age 50, the two common organisms are Streptococcus pneumoniae and Neisseria meningitidis. For age 50, it's still strep pneumo and Neisseria meningitidis, but also we add Listeria monocytogenes, and also aerobic gram-negative rods, but not Pseudomonas. So this is essentially like things like E. coli. For immunocompromised patients, it's strep pneumo, Neisseria meningitidis, Listeria, but also Staphylococcus aureus, Salmonella, gram-negative rods, including Pseudomonas aeruginosa. So Pseudomonas only a concern in immunocompromised patients. Patients with recurrent meningitis, it's usually strep pneumo, Neisseria, or H. flu. And patients with skull fractures, again, strep pneumo, H. flu, or group A beta hemolytic strep. And other CNS infections that we're not necessarily will cover in this lecture, but you have seen some of them in other places, is neurosyphilis. That's essentially CNS infection. There are a couple of fungal infections that are common, so cryptococcal meningitis and coccidioides meningitis. And then, of course, TB can manifest as meningitis too, so tuberculous meningitis. Now, let's talk about Listeria. So infections caused by Listeria species are referred to as listeriosis. And the genus Listeria contains 17 species, and only 3 of them have infected humans. And Listeria monocytogenes causes nearly all cases of human listeriosis. So the other ones are not really relevant, and they are short flagellated gram positive or sometimes gram variable, meaning that sometimes under the microscope they may actually look like gram negative, but in general they're considered gram positive rods. And one thing that's interesting about Listeria is that although they grow optimally at 30 to 37 degrees, they are able to grow at temperatures as low as 4 degrees. That includes the refrigerator, so it can grow inside the refrigerator. And they can be tolerant of high salt environments. So usually when you add a lot of salt, salt acts as preservatives, but not for Listeria. So if you can think of the type of food that's on this board, essentially the cheese and some of the meat here, so deli meat in particular can be contaminated with Listeria. Now, Listeria usually enters the human host via the GI tract. Foods that are associated with listeriosis outbreak includes melons such as cantaloupe, raw dairy that includes raw milk and raw cheese. Other things are ready to eat meat such as deli meat, sprouts, caramel apples, hot dogs, as well as pre-packaged salads occasionally get Listeria, as well as ice cream. And for most people, even if the food is contaminated, when they eat it, the acidic environment in the stomach should kill Listeria. However, if someone is taking antacids like proton pump inhibitors, that can increase the survival rate of Listeria. So in general, infection is relatively rare. Now, dysbiosis also leads to expansion of Listeria in the intestine, because if people have healthy microbiome, the healthy microbiome can outcompete Listeria for resources. So typically, again, people who are at higher risk may have dysbiosis. And once it gets to the intestine, Listeria, it can cross the GI border, disseminate from lymph node into the bloodstream to the spleen and liver, and across the blood-brain and placental barriers in the appropriate hosts. So essentially, once it makes it to the intestine, it will make it to other organs, and once it makes it to the blood, it can go to many places. So this is also a concern in pregnancy, because this can lead to complications of pregnancy, but also this can lead to CNS infections once it gets to the brain. We explained the pathophysiology and clinical presentation of central nervous system infections. Now, given a patient with suspected meningitis, let's recommend guideline concordant empiric treatment. IV antibiotics should be started within 1 hour of presentation if bacterial meningitis is suspected. Antibiotics with insufficient penetration into CNS should be avoided. Those include piperacillin tazobactam, specifically because the tazobactam part does not penetrate the CSF. Amoxicillin clavulinate, again, clavulinate component will not penetrate into the CSF. Aminoglycosides in general have poor penetration to the CNS, so they should not be used as monotherapy, but they can be used in combination with other antibiotics because of synergy. Clindamycin has poor penetration. Colistin is only useful for the infections in the urine, and the same is true for nitrofurantoin. And of course, vancomycin is not absorbed and should be avoided for any systemic infection. Now, select antibiotics based on suspected pathogens empirically. And if viral meningitis or encephalitis has not been ruled out, empiric IV acyclovir should also be added to empiric antibiotics until a viral infection is ruled out. Dexamethasone should also be started within the first dose, with the first dose of antibiotics, and it can be used up to 4 hours after starting the antibiotics, and should be continued for 4 days, unless the patient is known to be having Listeria monocytogenes, in which case, as soon as Listeria is isolated, dexamethasone should be discontinued, because in observational studies there was increased risk of mortality in patients with listeriosis who were receiving corticosteroids. Here are the empiric antibiotic choices based on the suspected pathogens. For most adults up to age 50, because strep pneumo and Neisseria meningitis are the suspected pathogens, the preferred empiric regimen includes vancomycin plus a third generation cephalosporin. Most people will use ceftriaxone. And ceftriaxone does not have great CSF penetration, so it should be used at maximal dose. So 2 grams every 12 hours is the dose that should be used for meningitis. Now, ceftriaxone will most likely cover these on its own, because there is a small chance that these organisms may be resistant to ceftriaxone. That's why vancomycin is added on top of that, to make sure that we get greater coverage, because of the increased risk of mortality due to the nature of this infection. For patients aged 50 and older, in addition to covering for strep pneumo and Neisseria meningitis, we should also cover for Listeria monocytogenes. And vancomycin and ceftriaxone are not active against Listeria. Therefore, we add a second, or I should say a third agent to cover Listeria. And this is one of the rare situations where you will have a double beta-lactam on board. In general, we want to avoid double beta-lactam due to increased risk of toxicity, such as neurotoxicity. But in this case, it is actually the standard of care to combine ampicillin and ceftriaxone. So ceftriaxone will take care of strep pneumo and Neisseria, and ampicillin will take care of Listeria. And of course, vancomycin will also be added. Alternative to ceftriaxone is, of course, cefotaxime, but again, most people will use ceftriaxone. The dosing is easier, and ceftriaxone is more readily available in places. In immunosuppressed patients, we also cover salmonella. So the recommendations are vancomycin plus ceftriaxone plus ampicillin. Now, immunosuppressed patients are at risk of also having Pseudomonas, but it's not recommended to empirically cover it if the patient does not improve on this, or if there is indication that there are non-lactose fermenters growing on gram stain, then these can be changed to cefepime to cover Pseudomonas. And patients with head trauma or post-neurosurgery, they should also cover Pseudomonas. So vancomycin plus cefepime, or vancomycin plus ceftazidime, or vancomycin plus meropenem. So here's what the overall picture looks like. So if somebody has bacterial meningitis, therapy started. If viral infection has not been ruled out, acyclovir will also be started along bacterial meningitis. In this picture, you will also see doxycycline in case there are tick-borne diseases. Doxycycline does not have a role outside of that. And then once empiric therapy is started, if cultures are negative within 2 to 3 days, we can stop antibiotics if no bacteria were identified. We can also use PCR for rapid diagnostics, and if nothing has been detected on PCR, again, we can stop antibiotics. But if something is detected, we can change empiric antibody to target specific pathogen. For the acyclovir part, if the PCR did not detect any viruses, we can discontinue acyclovir if the suspicion for having a virus is low. Otherwise, even if the PCR is negative and the suspicion for a viral infection is high, we can continue acyclovir until repeat PCR on CSF obtained more than 3 days later. And if the results of the repeat PCR is negative, then we can discontinue acyclovir. We explained the pathophysiology and clinical presentation of central nervous system infections, and given a patient with suspected meningitis, we recommended guideline concordant empiric treatment. Now, given a patient with confirmed bacterial meningitis, let's recommend pathogen-directed treatment. Now, once the susceptibility results are back, if the pathogen identified is Streptococcus pneumoniae susceptible to penicillin, then penicillin G is the narrowest antibiotic that we can use and has excellent penetration to the CSF. Now, these are all IV agents. So penicillin G is of course IV, and ampicillin is available as IV and PO, and of course we will be using the IV formulation here to maximize the concentration of these drugs in the CSF. Alternatively, if someone cannot tolerate these, we can use ceftriaxone or cefotaxime, and duration of treatment for Streptococcus pneumoniae meningitis is 10 to 14 days. Now, if the Streptococcus pneumoniae is not susceptible to penicillin, so if the MICs are elevated, we can use ceftriaxone or cefotaxime. As if someone cannot tolerate this, we can use cefepime or meropenem. And if the Streptococcus pneumoniae is not susceptible to ceftriaxone or cefotaxime, meaning the MIC is greater than or equal to 1, then we need to add vancomycin on board. So that's essentially vancomycin plus either ceftriaxone or cefotaxime. And in some experts recommend also adding rifampin. And in particular, rifampin is recommended to be added if it's susceptible. So if rifampin on culture results shows negative, then that should not be used. But if it's susceptible, and if the expected clinical or bacteriologic response is delayed, or if the pneumococcal isolate has a ceftriaxone MIC very high, it is helpful to add rifampin. But there is limited evidence to support this practice, so this is plus minus rifampin. Alternatively, vancomycin plus moxifloxacin can be used, and this combination also doesn't have much evidence behind it. Of course, we want to avoid ciprofloxacin because cipro is not active against strep pneumo. And then why not levofloxacin? In general, moxifloxacin will have lower MICs, and because we need to get enough concentrations in the CSF, it's recommended to use moxifloxacin for this in this case. If the isolated pathogen is Neisseria meningitidis susceptible to penicillin, again we use penicillin G or IV ampicillin, alternatively ceftriaxone or cefotaxime. Duration of treatment for Neisseria is 7 days. If not susceptible to penicillin, then we use ceftriaxone or cefotaxime, alternatively fluoroquinolone or meropenem. If it's Listeria, we use ampicillin plus minus gentamicin. And again, this gentamicin is added here plus minus because there's not great evidence behind it. Some observational studies have suggested there is increased survival in patients who also receive gentamicin. There is some synergy between ampicillin and gentamicin. Even though gentamicin has poor penetration into the CSF, observational studies suggest this might be helpful. And of course, this comes at the cost of toxicity. So this should be carefully selected in patients. Alternatively, trimsulfa is active against Listeria, and if someone could not tolerate that, meropenem is also an option. Duration of treatment for listeriosis is at least 21 days, and if the patient, at least 21 days, so it's based on how they're improving. So if the improvement is not great by 21 days, they may need the longer duration of treatment. For Streptococcus agalactiae, either ampicillin or penicillin G plus minus gentamicin. And again, not great evidence behind this, but aminoglycosides have been documented in vitro to have in vitro synergy against Streptococcus agalactiae when they were added to penicillins. Alternatively, third generation cephalosporins, and duration of treatment is 14 to 21 days. H-flu recommendation is ceftriaxone or cefotaxime. A lot of H-flus have penicillinases, so that's why ceftriaxone and cefotaxime are used. But if there is proof that these are beta-lactamase negative, then ampicillin can be used. Alternatively, cefepime, meropenem, or fluoroquinolone, and duration of treatment is 7 days. For enterobacteriales such as E. coli, ceftriaxone or cefotaxime, and assuming these are ESBL negative. Alternatively, ampicillin, meropenem, aztreonam, fluoroquinolone, trimsulfa, if susceptible on the culture results. Duration of treatment is 21 days. Now, if this happens to be ESBL producing E. coli, of course, we will go to a carbapenem as preferred therapy. For Pseudomonas, it's important to avoid piperacillin tazobactam because of insufficient penetration into the CSF. So preferred regimen is cefepime or ceftazidime, alternatively meropenem, aztreonam, or cipro if susceptible in the culture, and duration of treatment is 21 days. For MSSA, drugs of choice are nafcillin or oxacillin. Historically, if you look at textbooks, it's recommended not to use cefazolin due to insufficient concentration of cefazolin in CSF. In recent time, updated literature suggests that if you use high doses of cefazolin, such as 2 grams every 6 hours, this should be fine. Again, probably best to use nafcillin and oxacillin, but in case people could not tolerate these, cefazolin using high dose, because the normal dose is usually 2 grams every 8 hours, so higher dose would be 2 grams every 6 hours. Essentially, nafcillin, oxacillin are associated with increased hepatotoxicity and nephrotoxicity, so those would be the two top reasons for people not to tolerate these, whereas cefazolin is doesn't have significant effect on the liver or the kidneys. Alternatively, vancomycin or linezolid, and duration of treatment for Staph aureus meningitis is at least 21 days. If it's MRSA, we have vancomycin. Some experts add rifampin, but not great evidence behind that. Alternatively, trimsulfa if susceptible, and linezolid. For enterococcus that's susceptible to ampicillin, we use ampicillin plus gentamicin, and the role of gentamicin is synergy. So ampicillin alone is bacteriostatic against enterococcus, so adding gentamicin, it makes it bactericidal together. Of course, gentamicin is has a lot of toxicities, and ceftriaxone is not active against enterococcus, but when we use it in combination with ampicillin, again, it causes synergy. So this practice is extrapolated from treatment of endocarditis. So that's why there's a question mark. It has not necessarily been studied in meningitis, but some experts extrapolate this practice from endocarditis and use it because ceftriaxone plus ampicillin is less toxic than ampicillin plus gentamicin. Now, if ampicillin if enterococcus is resistant to ampicillin, then we just replace ampicillin with vancomycin. Adding gentamicin may have synergistic effect. There is no evidence that adding ceftriaxone to vancomycin has synergistic effect, so that's why it's not listed here. And lastly, if we have VRE, vancomycin resistant enterococcus, if it's also resistant to ampicillin, then we'll have to go to linezolid. And of course, this duration of treatment is 2 to 3 weeks. And for that duration, we're going to have significant toxicity from linezolid. So patients may not tolerate linezolid. So we also have high-dose daptomycin as an alternative to treat these patients. We explained the pathophysiology and clinical presentation of central nervous system infections, and given a patient with suspected meningitis, we recommended guideline concordant empiric treatment, and given a patient with confirmed bacterial meningitis, we recommended pathogen-directed treatment. Now, let's develop a patient-specific plan for the prevention of meningitis. It's important to distinguish between pneumococcal disease and meningococcal disease. So when people talk about pneumococcal disease, in general, they are referring to pneumococcal pneumonia or pneumococcal meningitis, which are caused by the organism Streptococcus pneumoniae, which is a gram-positive coccus. Now, this organism Streptococcus pneumoniae does have an outer capsule that's composed of polysaccharides, and because there is variation in this polysaccharide, there are more than 100 serotypes that are known. So the vaccines that we have are targeted at different serotypes. In general, we have two types of pneumococcal vaccines. We have pneumococcal polysaccharide vaccine. So it's literally they have taken the polysaccharides and they have put it in there. So Pneumovax 23 has 23 different serotypes in there. We also have pneumococcal conjugate vaccine. These are vaccines that are conjugated to a protein to improve immunogenicity. And there are currently 4 of them on the market. So PCV13, which targets 13 serotypes, PCV15, PCV20, and PCV21. Now, in contrast, we have meningococcal disease, which essentially means meningococcal meningitis. And this is due to organism Neisseria meningitidis, which is a gram-negative coccus, so it's very different than Streptococcus pneumoniae. And similarly, it has different, because it has a capsule, there are different serogroups. There are 12 serogroups that are known. Worldwide, serogroups A, B, C, W, X, and Y cause invasive disease, whereas in the US is more likely to be serogroup B, C, and Y. And there are different vaccines on the market. So, for example, there are the ones that target serogroup A, C, W, Y. There are some vaccines that target only serogroup B. And more recently, we have vaccine that targets all 5 of these that are most commonly causing disease, including Pembraya and Penmenvy. So if somebody wanted to prevent the risk or reduce the risk of developing meningitis, essentially because there are 2 organisms that cause meningitis, they need vaccination against Streptococcus pneumoniae, so pneumococcal vaccine, as well as vaccines against Neisseria meningitidis, so meningococcal disease. Now, when we give pneumococcal vaccine to people, so for sure, we are trying to prevent pneumonia, but more importantly, it is also reducing the risk of developing meningitis. So that's something important to keep in mind. In fact, when Streptococcus pneumoniae causes invasive disease, typically pneumonia, which can be non-bacteremic for the most part, but some of these can be bacteremic pneumonia. So, when you have bacteremia, it can make it throughout the body, and when it makes it to the brain, you will have meningitis. So these are relatively less common, but certainly more fatal. Now let's take a look at the available meningococcal vaccine products in the US. So we have 2 products that have Men-A-C-W-Y. So we have 2 of these, and then we have a couple of them that have Men-B. And then in recent time, we have 2 combinations that have all of these 5 combined in the same shot. And what you will see is that these are conjugate vaccines. So essentially, the ACWY is conjugated to tetanus toxoid, and Men-ACWY is conjugated to CRM197. Men-B is not conjugated, so it's a polysaccharide vaccine. And instead, since it's not conjugated, it relies on an adjuvant to increase immunogenicity. So it does have an aluminum adjuvant, whereas the conjugates, they do not have an adjuvant. These are all intramuscular injections. When we combined all of these into a single shot, these are essentially combinations of 2 vaccines. So you can see the one that Pfizer makes. This is a combination of their MenB plus Sanofi's vaccine. So this is a collaboration between Pfizer and Sanofi. Whereas GSK's vaccine that has all of them is a combination of their own MenB plus their own MenACWY. So you can see that essentially the protein carrier and will match what's being combined in the vaccines that includes all five. Here are the ACIP recommendations for meningococcal vaccine. So the one that has MenACWY, 2-dose series is recommended for patients who have asplenia, complement deficiency, or HIV. Of course, that includes a booster every 5 years. For other patients, such as those who travel to epidemic areas or microbiologists that work with this organism, just a single dose is recommended, and then booster every 5 years as long as the risk of exposure exists. For first-year college students who live in residential housing, if not previously vaccinated at age 16, a single dose is recommended, and as well as for military recruits. MenB is recommended for patients with asplenia, complement, and of course microbiologists that work with Neisseria meningitidis. And MenB is a 3-dose series plus booster every 2 to 3 years. The first booster should be 1 year after completion of the primary series. Now, adults may receive a single dose of Pembrya, which includes ACWY and B in the same shot. If both of these are indicated in such patients. Now, as of this recording, there are 5 pneumococcal vaccines available on the market. The first one is the Pneumovax 23. So this is targeting 23 different serotypes, and it is approved for age 2 years and older. These are essentially all of them 0.5 ml intramuscular injections, but Pneumovax can also be administered subcutaneously, and they all need to be stored in a fridge. So refrigeration is required, but not freezing. Prevnar 13 targets 13 of these serotypes. Then we have Vaxneuvance, which is PCV 15, Prevnar 20, which is PCV 20, and Capvaxive, which is a PCV 20. Now, with the exception of PCV 21, they're all approved for adults and children. And the PCVs, which are pneumococcal conjugate vaccines, differ from PPSV, which is polysaccharide vaccine. They're essentially conjugated to CRM197 carrier protein. So all 4 of the PCVs are, that's how they are conjugated, and that improves immunogenicity, which I'll explain in a minute. But also another thing to keep in mind that PCV 13, 15, and 20 also have aluminum in them as an adjuvant to further enhance immunogenicity. The latest one that has come to the market, PCV 21, does not have this adjuvant. So that's something to keep in mind, and I'll mention that shortly. Now, let's take a look at some of these vaccines. So PPSV 23, which is the oldest one on the market, came to the market in 1983. Because it's pneumococcal vaccine, it does not depend on T cells. And because, infants or toddlers under the age of 2 have not matured their immune system, you're essentially not going to have immunogenicity in age under 2 years. So PPSV 23, for that reason, because it does not activate the T cells, it is not used for under age 2. Now, this does cover 23 valents, and essentially the studies have never shown that it can actually reduce the risk of pneumonia, but certainly it can prevent invasive pneumococcal infection, specifically meningitis. So there is certainly value in administering it to people. And then PCV 13, which is the better formulation, so it's conjugated, so it has enhanced immunogenicity that depends on T cell, and for that reason it does work in children under the age of 2. So it's approved for anyone 6 weeks old and older. So it's part of, or it has been part of childhood immunization schedule. and in fact, it came to the market for children first before it came to the market for adults since 2010. And it has been proven to prevent not only meningitis but also pneumonia. So PCV13 is definitely more valuable than PPSV23, but because it only covers 13 serotypes, they definitely need to be administered in combination, not necessarily at the same time, but I'll go over the schedule shortly. Now, the new pneumococcal vaccines, so PCV 15, 20, and 21, have come to the market in the past few years. So since in 2021, we saw that PCV 15 and 20 came to the market for adults first, followed by approval for children. And PCV 21 currently is only approved for adults. Now, these are essentially come to the market based on immunogenicity data. So we don't have efficacy data for any of these. So in other words, nobody has done studies to show that they can prevent pneumonia or meningitis. What they have done is to show that they can trigger the immune system to have antibody response against these serotypes that are included. So PCV 15, 20, and 21, they all have shown that they can have robust immune response. Now let's take a look at guideline recommendation from CDC's ACIP for adults. So there are 4 different groups of people that we can take a look at, and for each of these groups we can also look at age cutoffs. So in general, there are recommendations for people age 50 years or older, and of course from age 19 to 49. And then these are for people who are pneumococcal vaccine naive or unknown status. So in other words, for people who have received their full pneumococcal vaccination during their childhood immunization, these recommendations do not apply to those people. And for many of these people, when they were children, essentially for most of these people, pneumococcal vaccine for childhood immunization did not exist. So large majority of older people will most likely be pneumococcal vaccine naive. So the first group is healthy people, and this is essentially people with no other risk factors. So essentially, since these people do not have risk factors until they are 50 years old, there is no recommendation for receiving pneumococcal vaccine. And then once they turn 50, it is recommended to receive 1 dose of a PCV vaccine. So that could be either 1 dose of PCV 15 or 1 dose of PCV 20 or 1 dose of PCV 21. And then for PPSV 23, it is recommended to receive 1 dose of PPSV 23 if the patient had received PCV 15. In other words, if the patient had received PCV 20 or 21, there is no need to also get PPSV 23. Now let's take a look at the timing of these vaccines. So essentially, if people need to get these, it is, if it's PCV 20 or 21, it's just a single vaccine. So there is no PPSV 23 to follow. So that one is straightforward. However, if the patient is to receive PCV 15, it is recommended to get the PCV vaccine first because the PCV vaccine is the most effective. And then at least a year later, they can get the PPSV 23. So PPSV 23 is less effective, less immunogenic, but it will add extra coverage for those extra serotypes that are not included in PCV 15. It is important to keep in mind that PCV and PPSV 23 should not be co-administered in the same visit. So there has to be, some time between the 2 doses. So they should not be given at the same time. Now, if for some reason somebody had already received PPSV 23 and now they're coming to you and then you realize that they have not received their PCV, it is important to give them one of the PCVs. And at this point, you can do PCV 20 or 21 as well. But again, it has to be at least 1 year apart. Now, vaccine doses do not need to be repeated if given before age 50 years. In other words, if somebody had received PCV 20, let's say at age 45, once they turn 50, they do not need to be repeated. When PCV 15 is used in those with history of PPSV 23, it need not be followed by another dose of PPSP23. So again, so if that PPSP23 was given, let's say at age 45, once they get their PCV15 at age 50, there is no need to chase it with another PPSP23. Now let's take a look at the second group of people. So this is the immunocompetent people who have some risk factors for pneumococcal disease. And those risk factors include alcoholism. And alcoholism, per CDC's definition for female, is having 4 or more drinks on an occasion in the past 30 days. And a drinking occasion is considered to be approximately 2 hours. So, if there is a party and within the 2 hours, there were 4 drinks consumed, that would be considered. And for males, the same definition, but it's 5 or more drinks on an occasion. Next is chronic heart disease. And this is things like coronary heart disease or heart failure, but not hypertension, chronic liver disease, such as cirrhosis, chronic lung disease, such as COPD, cigarette smoking, and diabetes mellitus. So for these group of people who have risk factors, but they are considered immunocompetent, it is recommended to get a dose of PCV before age of 15. So sometime between age 19 to 49, they need to get 1 dose of any of these. So it could be PCV 15, 20, or 21. And of course, if they do get PCV 15, it is recommended to follow up with a dose of PPSP 23 just to give those extra coverage. If it's PCV 20 or 21, there is no need to get the PPSP 23 because 20 and 21 give enough coverage. So again, here's the timing. PCV 2021 is just a single shot. If it's PCV 15, at least 1 year later, there will be a PPSP 23. Now, for this group of patients, once they got their complete immunization of pneumococcal vaccines before age 50, when they turn 50, they don't really need to get vaccines. However, if they had not previously received the vaccine, once they turn 50, they should get their PCV vaccine. And of course, if that PCV happened to be a PCV 15, they also need to chase it with a PPSV 23. Otherwise, if somebody has completed these vaccines prior to age 50, neither PPSV or any PCV is needed after age 50. For the third group, which is immunocompetent persons but with a super extra high risk, so these are patients with CSF leak and cochlear implants. So these are very high risk of getting pneumococcal meningitis. And the fourth group is immunocompromising conditions such as asplenia, cancer, chronic renal disease, HIV infection, immunodeficiency, sickle cell disease, and solid organ transplant. So for these last 2 groups, the recommendations are still the same. So prior to age 50, they do need to get a complete series of PCV followed by a PPSV 23. And then once they turn 50, they don't really need to get anything unless they have not previously received one, then they complete. The only thing different for group 3 and 4 is that if they do get PCV 15 and they need to chase it with a PPSV 23, the time between the 2 can be shortened to 8 weeks just because these are super high risk patients. So you want to accelerate their full protection. So therefore, it is recommended to, instead of waiting 1 year after PCV 15 to give the PPSV 23, to do so within 8 weeks. And of course, if for some reason the patient had already received PPSV 23, it will be 1 year later that they will get any of the PCV vaccines that are available on the market. Now let's take a look at Haemophilus influenzae. The majority of H. flu disease is caused by serotype B, so HIB. And you can see that it can, so it's all the disease caused by HIB, about half of them include meningitis, 12% pneumonia, and other infections. And this is associated with significant mortality. So you can see pneumonia caused by Haemophilus influenzae has significant mortality. The same is true for meningitis due to this organisms. So we have several vaccines available, and of course HIV is part of childhood immunization, so you can see these are approved for children. So we have 3 formulations available, and these are conjugate vaccines. So depending on which formulation, there are different protein carriers, and what they're carrying is the essentially polyribosyl ribitol phosphate, which is the polysaccharide that's in H flu. And these are all intramuscular injections. And then because there are so many vaccines during the childhood vaccination, there are also combination formulations that are available. Again, these are for children. So as you can see, the 3 vaccines that are available, at most it's for up to age 5. So the question is, what do we do in adults if they need it? And these are the recommendations from ACIP. So patients with anatomical or functional aspleenia, it is recommended 1 dose if previously did not receive HIV vaccine. In other words, if someone missed their childhood vaccination. Now, patients who are undergoing splenectomy, 1 dose preferably at least 14 days before splenectomy. And patients who have hematopoietic stem cell transplant, 3-dose series, 4 weeks apart, starting 6 to 12 months after successful transplant, regardless of HIV vaccination. So these are recommendations in adults. So no HIV vaccine is FDA licensed specifically for adults, but any of them essentially can maybe use off-label in adults for the above ACIP recommendations. So that's something to keep in mind, that in the pharmacy you can use them off-label for these indications. Now for listeria, which is foodborne, there are recommendations for prevention of exposure. Of course, the most important is washing and handling food. It's important to rinse raw produce thoroughly. Even if produce will be peeled, it should still be washed first. Scrub firm produce such as melons and cucumber with a clean produce brush, and dry produce with a clean cloth or paper towel. Keep the kitchen cleaner and safer. Wash hands, knives, countertops, and cutting boards after handling and preparing uncooked food, and clean up all spills in the refrigerator. Remember, this can grow in the refrigerator, especially juices from hot dog and lunch meat packages, raw meat and raw poultry. It's important to cook meat and poultry thoroughly. So cook raw food from animal sources. Use pre-cooked or ready-to-eat food as soon as you can. Do not store the product in the refrigerator beyond the use-by date, and use leftovers within 3 to 4 days. Choose safer foods. Do not drink raw or unpasteurized milk, and do not eat foods that have unpasteurized milk in them. For meats, it's important to cook them to an internal temperature of 165 degrees. For cheeses, especially soft cheeses such as feta, queso, eat only soft cheese that is made with pasteurized milk. For seafood, do not eat refrigerated smoked seafood unless it is contained in a cooked dish. Of course, canned and shelf-stable tuna, salmon, and other fish products are safe to eat. For melons, again, scrub them and clean them thoroughly. Promptly consume cut melons or refrigerate promptly. Keep cut melon refrigerated for no more than 7 days. Discard them if they have been at room temperature for more than 4 hours. For raw sprouts, do not eat any kind of raw or lightly cooked sprouts, and ask that raw or lightly cooked sprouts not be added to food when eating out. Cooking sprouts thoroughly can reduce the risk of getting sick. This concludes this presentation.